Hi dear doctors, welcome to the class of Kids Covery. I am your pediatric faculty, Dr. Parv, and we are going to learn the topic of pediatric orthopedics, that is juvenile idiopathic arthritis, which is called as GIA also. So what is juvenile idiopathic arthritis? The name is suggesting itself that it's a disease which is seen in juvenile population. It is a disease which is having arthritis, inflammation of joints, and the reason is not clear, that is idiopathic. So juvenile idiopathic arthritis is the most common rheumatic disease in children, which is comprising of a group of disorders which is characterized by chronic arthritis. Okay, so basically it is idiopathic, but we feel that it's a rheumatic disease, it's an autoimmune disease. So what happens is that it is the most common rheumatic disease. So what happens is there is an autoimmune disorder. Okay, because it's a rheumatic one, no? So it's an autoimmune disorder which is going to have abnormalities like humoral mediated and cell mediated abnormalities that is responsible for causing inflammation of the synovial membrane. Inflammation of the synovial membrane that is going to have a lot of blood supply, because whenever there's inflammation there's going to be a lot of blood supply. That's the reason for the edema and the rubor which is going to be developed at the site of the inflammation. Now the blood supply is more, so of course there will be synovial edema which is going to be there, and that leads to the pannus formation. So pannus formation is going to occur, and ultimately what is going to occur, because the synovial membrane is getting swelled up, okay, and a lot of inflammatory processes going, lot of WBCs will accumulate. They are going to eat up the normal cartilage and the bone, and there will be erosion of the cartilage and the bone. So this is what happens in idiopathic arthritis. Very sadly, the child is going to have synovitis, the child is going to have pannus formation, and the child is going to have erosion of the cartilage as well as bone. So these 1, 2 and 3 things are very important to be remembered. We have seen that juvenile idiopathic arthritis is seen like in the oligoarthritis, where less than 4 joints are involved. In polyarthritis, more than 5 joints are involved for JIA. So just remember that juvenile idiopathic arthritis is going to have polyarthritis, 1, 2, 3, 4, having more than 5 joints involved. Oligo, 1, 2, 3, 4, 5 letters, less than 4 joints are going to be involved. And sometimes juvenile idiopathic arthritis is a systemic condition also. That means it is going to have the systemic manifestations like arthritis with fever, with the rash. So now it becomes a systemic disease. There will be fever which is going to happen, there will be rash which is going to happen. Of course, arthritis is something that is going to happen. Now, all the autoimmune disease for that matter are most commonly seen in the female gender. The girls are having a high predominance of these diseases. Okay. Now, what are the general symptoms? Of course, you will be having joint pain, joint swelling. But what happens in idiopathic arthritis, say there is morning stiffness, okay? There's going to be morning stiffness which is going to be there, and early afternoon fatigue which is seen, okay? There's a morning stiffness which is there in JIA, and this is something which you have to understand, okay? Because it's an autoimmune disease, okay? It's an autoimmune disease. See, very simple thing, let me just teach you. Like for example, if you're moving any limb, there the inflammation is going to be slightly less than the normal things, because it's an inflammatory condition, and if you're not moving the limb for a longer period of time, like in the night time, this inflammation is going to increase, and that's why the child is going to have morning stiffness, okay, right? So this is something which you have to understand. So of course large joints are getting involved, and since it's an autoimmune disease, we have seen that uveitis risk is very high in GIA. Okay, in GIA there is a high risk of uveitis which is involved, and you have got some subtypes like oligoarthritis. Subtypes means although the less amount of joints are involved, but the large joints are involved. Less joints are, oligo means what? Oligo means less joints are involved, but we have to understand large joints are involved, number 1. Second thing is going to be uveitis risk is also high. Coming on to next, polyarthritis. Say in poly, many joints are involved. Many means both, many small joints, many large joints are going to be involved in symmetric arthritis, and of course the poly is going to be symmetric also, which actually resembles the rheumatoid arthritis of adults, okay, and in this the rheumatic factor is also very much common. It can also involve the spine, the hip, the temporomandibular joint, all these things are involved. So for polyarthritis, you can use the 4 alphabets P, Q, R, S. So P for polyarthritis, Q nothing, R rheumatoid factor positive mimics RA, S for symmetric, and of course S for spine is also involved, PQRST, T for temporomandibular joint which is involved, and 1 T you can use for thighs, so you can remember the hip also. Coming on to systemic, so I have told you that there will be fever, there will be rash, but which type of rash? There will be salmon colored macular rashes. Okay, there will be which colored? Salmon color macular rashes. Just remember S for systemic JIA, S for salmon colored macular rashes. So what is the diagnostic criteria? She or he should be juvenile, so definitely less than 16 years of age, and juvenile idiopathic arthritis. So arthritis should be, yes, arthritis should be in more than 1 joints, because even if it is oligo, it's going to be less than 4, but of course more than 1, and poly has got more than 5 joints involvement. And what is the duration? So duration should be more than equal to 6 weeks, and there is no single confirmatory test which is there. So just remember, if you remember 16, everything is solved. That means 1 states that more than 1 year, 6 states that duration more than 6 weeks, and 16 states that 16 years is the age of the child. So in laboratory findings, please understand that there is increased in amount of WBC. Why? Because of inflammation which is going on, and of course there is a anemia of chronic disease, microcytic hypochromic anemia of chronic disease which is going to happen. Then ESR and CRP are elevated because of course it's an inflammatory disease. Rheumatoid factor can be present if it is polyarticular, but ANA is present if it is a oligo-articular disease. So actually now oligo-articular you can remember with the help of 2-3 vowels. So oligo, A for ANA positive, U for it is going to have uveitis. Okay, so UIE, 3 letters can together join and form uveitis. So this is how you can remember. Just to show you once again, this is the normal overgrowth which is going to be there. There's no overgrowth in normal one, but there is a overgrowth which is going to happen. So this was supposed to be the normal size, whereas if you see, this is the normal size. Okay, which this is the abnormal size which is there. So this overgrowth, but of course the bone is not going to be dense, the bone is going to be lytic, osteopenic, that is going to be there, and that is why there is going to be a decreased joint space. Why? Because the bone growth is too much. In the case of arthritis, any inflammation is going to have enlarged, that structure is going to get enlarged. So of course I have told you that because inflammation is there, there will be soft tissue swelling, and there will be periarticular osteoporosis which is going to be there. In MRI specifically, you will have early synovial changes and erosions. In MRI, you will have early synovial changes and erosions which will be seen. Now, what is the pharmacological treatment? See, this is idiopathic inflammatory case. So we have to give anti-inflammatory. So we give NSAIDs, we give methotrexate. Okay, so methotrexate will be given in polyarticular cases, and of course in the resistant or oligoarticular cases, and NSAID is given in the oligoarthritis. So no PM. No PM means NSAIDs in oligo, P for polyarthritis, M for methotrexate, and of course we can give some biological DMARDs also, like infliximab, etanercept, etc. for methotrexate resistant cases. Okay, so what are the serious complications? See, we have seen that there is a macrophage activation syndrome which has happened in the patients who are suffering from juvenile idiopathic arthritis. Now, what is macrophage activation syndrome? See, what happens is there is a defective downregulation of the immune system. I'm repeating my words, defective downregulation. So if the downregulation is defective, there will be upregulation. If downregulation is defective, there will be upregulation. So upregulation of the immune system, that is responsible for causing multi-systemic inflammation. So what happens? Immune system is not downregulated. That means macrophages are overactive, T cells are overactive. That leads to cytokine storm, and this cytokine is responsible for causing multi-systemic inflammation. And now, since the inflammation is too much, if now the inflammation is too much, what is going to happen? There will be platelet which will be consumed. So because the platelets is consumed, this is called as thrombocytopenia. The child is going to have fever, the child is going to have hepatosplenomegaly, the child will have lymphadenopathy, the child will have purpura. Okay, and the fibrin split proteins like the D dimers, they are also going to be very high. So So D dimers are nothing but just the marker of inflammation only. PTT time are going to increase because there is no sufficient amount of platelets, and we will do a bone marrow biopsy in this case to see a lot of active T cells proliferation which is going to happen. Okay, but the question arises that why there is defective down regulation? Because my dear friends, the things are very simple. It's an autoimmune condition. The body wants to have a lot of immune cells, and in order to create a lot of immune cells, the body has to work a lot. That's why there is no down regulation of the immune system. Please understand ANA positive patients. So all the budding ophthalmologists, please understand that ANA positive patients are having a higher risk of uveitis. So please screen them, okay, every 3 to 4 months. That is important. So this was the topic of JIA. Thank you so much for watching. God bless you.